let's talk about some myths in medicine. This is a little complicated. We're talking about the conscious perception of pain. Now, if you have somebody who is in the ICU with anoxic brain injury, and you've done everything initially that you can do, you cool the patient, you give him whatever you need to give to trying to protect him, but now we are talking about somebody who is irreversible anoxic brain injury, and one of your job as a ICU attending or hospitalist or whoever is taking care of the patient, primary care doctor, surgeon, your job is to actually tell the family the prognosis. Well, if you keep giving fentanyl for this patient or Versed or any of these medications, Valium or whatever, and you go to the family and say, well, your father is never gonna wake up, and some little guy in the room comes up with this idea that he saw on WebMD and ask you, but doctor, could it be the sedation that is causing him to be asleep like this? And if you hesitate for a moment, and if you say, well, maybe, but I don't think so, that's it. You lost the trust of the family, because you just wanted to kill their father, right? You just wanted to terminate his life, but you told them something, and they because they didn't trust you, one of them said something, and it turned out to be the truth. It turned out to be there's a percentage. And if you had watched Dumb and Dumber, what did Jim Carrey say when he went to the lady and said, what are the chances of a boy like you, and he watched it, he said, a boy like you has any chance to go out with a girl like me? She said very low. He said, how much? Like 1 in 1,000? She said, no, more like 1 in 1,000,000. So he paused for a little bit, started jumping all over, and then he said, so you're saying there's a chance? You know what I mean? So if you tell the family that, yeah, well, it could be, it could be the Versed and fentanyl, it could be, maybe it's, less than 5% chance that this is the situation, then they're gonna say, you're an idiot. We want the 5%. We want our father to live, and rightfully so. So you can't do that. So you have to be sure before you go to a meeting like this that the patient is never gonna wake up. And in order to do that, if feasible, you continue the patient on propofol, Presidex, maybe plus or minus Nimbix. You don't want to give any other medication, because all of the other medications are long-acting. In fact, in some hospitals, the criteria for pronouncing brain death, it indicates that there is no, or it requires that there is no Versed or fentanyl or long-acting neurotropic medications that are given in the last 24 hours, sometimes 48 hours, to pronounce brain death, which is a little bit more legal entity, right, than irreversible brain damage. So the point here is that you have to avoid those, if by all means, if you can do it. So, for example, if the propofol is less than, if the levofit is less than 20, you can use propofol, right? Just to at least make sure that the patient doesn't wake up, because that's the most important thing actually for this patient, is to wake up to determine if you continue to work on him or not. So, so the point here is that you want to start using propofol only, okay? Now, the nurse is going to come to you and say, you are cruel, you are a bad doctor, because you're leaving your patient in pain, and you're going to be puzzled. How does she know that the patient is having pain? How does she know? She knows that the patient is having pain because the patient is tachycardic and hypertensive. That's exactly how the anesthesiologists know that the patient is having pain under anesthesia. The patient will be asleep, and then is tachycardic and hypertensive. And that's how they know that the patient is having pain, right? But the point here, you don't want to give pain medicine. The only medication that is acceptable to be used in this situation is remifentanil. Remifentanil is $12,000 per day. so expensive. Maybe less now, a little bit, but it's so expensive to be used as an infusion, right? So why use it altogether? You shouldn't use it, right? And you should stick to the propofol. But yes, are you cruel? Are you causing the patient to have pain and then suffer from the pain and all this? No. You have to explain to the nurse and tell her that the patient is having nociception, but not conscious perception of pain. The patient is not having conscious perception of pain. The patient is having nociception, right? Nociception is just how the pain as a stimulus is transmitted through the nerve and the nerve receptors, the nerve fibers, and going all the way to the spinal cord, and even going up to the brain, to the thalamus, and then the corona radiata, and all of these things. And that's the end of it. That's the end of perception of pain, of the nociception. Now, after that, the pain goes to different places, or the results of the pain goes to different places. So it stimulates the conscious center. So the conscious center have a conscious perception of the pain, and that's where the suffering comes from, right? And it keeps it as a memory also. And also goes to the sympathetic system. It's close to the thalamus, and it stimulates the sympathetic system. Right? That's how we protect ourselves in the body. The sympathetic system goes up. But they're two different things. The conscious perception of pain and the sympathetic system are two different things. And it all depends on, so if you want a proof on that, I was just reading about it. I was reading, and it always says that you have to refer to the anesthesiologist to explain to you. So let's refer to the anesthesiologist to explain that, right? So if the anesthesiologist is in the OR giving gas anesthesia, right, and the patient is completely asleep, unconscious, completely, and the surgeon is working in the abdomen, and then suddenly the surgeon decides to take a skin graft. The skin is more stimulating than the abdomen, so he doesn't tell the anesthesiologist. He comes out of the abdomen, he takes the skin graft, and suddenly the patient is tachycardic and hypertensive. The anesthesiologist jumps from his or her stupor and leave the phone on the side and start looking at the patient and say, what had happened? What's going on? Why didn't you tell me that you're taking a skin graft? Right? That's fine, and then you end up giving fentanyl to the patient, and that's it. Does this patient wake up in the after in the recovery room and say, doctor, thank you very much, you gave me a good anesthesia, but I felt at 12:30 in the afternoon, I felt some pain in my thigh? Of course not. Of course he doesn't say that. Why? Because he did have nociception that went all the way to stimulated the sympathetic system, and when it tried to stimulate the conscious system was unconscious. So there's no record of that pain. So that patient, no record that patient that actually was tachycardic and hypertensive in ICU with an oxic brain injury running on propofol drip, there is nociception, but that pain is not perceived. I don't know who is perceiving the pain. Who knows who's perceiving the pain, right? Maybe God is writing up there, there is pain in room 12 in ICU at 11 o'clock at night. That pain is not perceived by anybody. Let's inflict it on Hitler. Could it be? This excessive pain may be inflicted on some other people. Maybe. They deserve more pain. Who knows? Who knows? Right? All I know is that my patient is not suffering from pain. That's all I care about. This patient is not suffering from pain. He's having nociception. Okay? Now, we have to understand the mechanism of medications, how it works. This is one of the weak points in our system of education, right? We don't understand the mechanism of how the pain works, the medications work. So, for example, amnesia. When we talk about nociception and conscious perception of pain, it looks like amnesia will be a great asset. We want amnesia, right? Because amnesia is gonna prevent the memory of pain and the conscious perception of pain. Amnesia, how easy or how difficult and how does it work to actually give amnesia to the patient or inflict amnesia on the patient, right? For example, if the anesthesiologist forgot to turn the gas on, right? It doesn't happen that frequent, but let's say somebody forgot to turn the gas on, or the gas was empty, right? The bottle was empty or whatever, some mishap, the gas was not turned on and the patient was paralyzed and the surgery had started. What does the anesthesiologist do? The anesthesiologist give a good slug of Versed. Why? Versed erases memory, so it causes amnesia, antegrade amnesia. It also causes retrograde amnesia. So amnesia before Versed was given. That's amazing to me. That is amazing. Of course, nobody knows exactly how memory is being done, being formed, and where is it stored exactly, because it's stored in multiple places. But we have some idea. So the memory has something to do with messenger RNA. So if I see you now, I will see, a person in front of me. I'm gonna that's gonna be a memory. It's gonna be a messenger RNA that's forming protein that actually encodes for this memory that I saw you. And if after it encodes for it, it becomes a protein, and this protein gets stored, right? And when I sleep at night, the brain actually files this stuff. It puts each memory wherever they belong, and there's a big emphasis on where does important memory go. So if it's something that is so emotionally provoking to me, that I saw you, I was so happy to see you, or I was so scared to see you, this memory is going to be put in the permanent files, where I'm probably not going to forget it for a long time. But if I just saw you and I see you every day, this memory is going to be placed in the temporary files that are probably going to be erased when the brain needs more room, right? So that's like the rough way of doing it. So if I have pain now and you give me not fentanyl, Versed, 1 second or 1 minute after I had the pain, a good dose, I probably will forget completely that I had pain during that time, because the messenger RNA started to form, but you cut it before it formed protein, right? That's important. Okay, you don't believe me. Okay, maybe you should come to the holding area of the OR, where a good conversation happened between the anesthesiologist and the patient to keep them calm and to reassure them and stuff like that. And after this good conversation, a Versed is given, so the patient doesn't have to be anxious as he's rolling into the OR, and the patient is still talking. Maybe eyes closed a little bit, but you can wake them up and say, scoot over to the OR room or whatever, or table or whatever, and they do this stuff, but they forget about it. A great percentage of them forget completely about all the trip from the holding area to the OR, and also sometimes they forget even a little bit before, which is the last conversation they had in the holding area, right? That's amazing. So that means that the memory that you're having and the conscious perception of pain can be erased with propofol and Versed and all of these things. Add to that an anoxic brain injury, 100% is going to be erased. Okay? So the answer to the question is that yes, if the patient is asleep, right? And we have documentation from the BIS that he's asleep, or the dose is correct on propofol and it's running in the vein and all these things, chances are this tachycardia and hypertension are just a sympathetic response to pain, but has nothing to do with the conscious perception of pain. Don't worry about it, don't treat it, don't do anything about it. Okay, you still don't believe me. All right, read the anesthesiology books. The anesthesiology books talks about MAC and MAC bar. MAC is the minimum alveolar concentration of the inhalation anesthetic that puts half the patients to sleep. MAC bar is the minimum alveolar concentration that eliminates the autonomic response in 50% of people. And to give you an example, sevoflurane, for example, the MAC is 1.2% and the MAC bar is 3%. Okay, so when we do TIVA for total intravenous anesthesia for in neuro cases, what we do, we put the patient on remifentanil infusion and propofol infusion. What is the propofol dose? 200 mics per kilo per minute. What's the usual dose of propofol in the ICU? 50 mics per kilo per minute. So the ED90 of propofol is 50 mics per kilo per minute, and the ED90 to inhibit ED90 bar to inhibit autonomic responses are 200 mics per kilo per minute, right? So that shows you that there is difficulty in controlling the sympathetic response. Sympathetic response 4 times the dose in propofol to control the sympathetic response. But the conscious perception of pain, 50 mics, even lower than 50 mics, you're not going to be conscious to the pain and you're not going to suffer from it, right? So the graph that I like to draw all the time is basically the dose that is required to actually achieve amnesia, right? From Versed, for example, is very tiny, very tiny. When it's well timed, it's very tiny. The dose that is required to cause unconsciousness, like patient closes his eyes and looks sleepy, looks asleep, that's higher. And the dose that is required from Versed to achieve immobility is even higher. And the dose required to achieve barring autonomic responses, is even higher, the highest, right? So don't conflate the doses together. Don't conflate these doses together. The dose for Versed is very small for amnesia, a little bit higher in unconsciousness, a little bit higher in immobility, and a little bit higher in bar. So I've seen ICU nurses, for example, they conflate them together. If a patient could be completely unconscious, but his leg is moving, and they increase the dose of sedative. That's wrong, right? The patient is supposed to move. He's unconscious, but he's moving. He's supposed to move. When you're asleep, you move, right? When you're asleep, so you can keep turning and move your muscles and don't get pressure ulcers when you're asleep and stuff like that. Same thing here when somebody's unconscious in the ICU. You can't conflate both together. And more dangerously, by the way, some ICU nurses treat autonomic responses treated with sedation. That is the most dangerous out of all. If somebody is asleep, but he's tachycardic on his BT or tachycardic when we turn him or whatever, and they increase the Versed or fentanyl for that reason, which results in disasters, and the patients never wake up. All right? I hope that explained the topic. Thank you.